Welcome everyone to the HMOTA Home Modification Occupational Therapy Alliance meeting. Thank you all for coming, and a special thank you to Bethany. She set up our speaker tonight, who is Sarah Szanton from John Hopkins. She's in charge of the Capable program.
Sure. So my name is Sarah Szanton. I'm a professor at the Johns Hopkins University School of Nursing and the School of Public Health. And I'm a nurse practitioner and have done a lot of work with low-income older adults in their homes. And so although I was there under kind of a medical model, it is how important the home environment is. They're telling them that they should get exercise, but there's holes throughout their floor, or they can't get down their front steps. It's more difficult to. And so in so in I got to thinking about what could help employ people, kind of like what you guys were just doing about after the hurricane and rebuilding, thinking about what could we do to help employ people who had been affected by the housing recession, and thought, wow, wouldn't it be cool if we, oh, there's the slides. If, oh, yeah, okay. I, oh, dang, a year old for huh.
If I touch my screen at all, it'll go small like that. So I'll try not to touch the screen, but I'm gonna mute everything. So just so
Okay.
you know, that's why it would go up and down. But I can hear you, obviously. You just won't be able to hear me.
Okay. Okay. And so these aren't the perfect. I hope this has results. I think this probably can you take the slider and sort of slide it just so I can see all the slides, like at the on the right, yeah, right there where you're headed. Um, just okay. I was just trying to see towards the end. Yeah. Um, results. Huh. Guys, other slides later. Um, then then we can. Yeah, there's some good results. Okay, yeah, that's great. Thank you so much. That's so you can go back up to the beginning. Thank you, Karen. Okay, so you can just go. We can skip. We talked about who me, and we don't have to talk about my career path. And so we'll just start with Mrs. B there on the third slide. So I was just saying that. So you don't see the notes underneath and don't see the other slides. But yeah, thank you so much. You're really good at this, even muted. I was just visually makes the point that I was making verbally, which is that you all already know how important the home is, but a lot of times the medical system, nurses and doctors and other colleagues that you all have don't really understand the intersection between um, home environment and function. And a lot of times people don't understand the relationship between function and chronic conditions. People think that things like diabetes and heart failure are what drive healthcare costs, but really it's physical function, sometimes as a result of those problems. And so I was starting to design a program with nursing visits and home modification when I came across Laura Gitlin's really important work that she developed called the ABLE program in Philadelphia, that was with an occupational therapist and home modification. So I reached out to her and we kind of put it together. Her program, ABLE, and then this idea about adding nursing and home repair. And so the ABLE and capable is on purpose. It's building from her ABLE work. And we added nurse and home repair. And if that's hard to do, I guess you could go back to the view that you had before.
I'm sorry, did you ask me?
So we don't.
Your phone, the volume's going out a little bit. So you want to go like right here?
Oh, yeah, to the next slide after. Yeah, and the next slide after. Thank you. So we built her a closet. We got her a closet, but this was a closet before we became involved with her. And you can see there's just a sweater bag, and so that kind of gives you a clue for why she was sitting basically in a house coat dress. Also, she had a front rotator cuff that had never really gotten, and so it was hard for her to get dressed that way. For her working out.
Is Hey Sarah, you're breaking up a little bit. Is she breaking up for anybody else besides me? She's fine. Okay, good. It'll record that. Ooh.
I'm quiet. Okay, is that better? I put the headset a little closer to my mouth. Is that better?
That sounds better to me. I feel like I'm just not catching when you want
Okay,
me to trade.
great.
I'm not catching everything. Bah.
Okay. All right, I will try to enunciate. It's the end of a long day for all of us. Okay, so maybe I'll also pull up the slides on my computer so that I can see. If you can't advance, I can still at least keep talking. So if you are able to advance, that would be great. And if you can't, I will just, okay, so this was her floor, and this was after we fixed it. And she had holes throughout her floor, including a 2 foot by 1 foot hole right by her front door. So she sat in that chair that you saw her in almost all day, and you can see she was almost maybe safer to sit in that chair. Okay, next slide, please. And these were not her back steps, but this is fairly common, as you probably know, when people, put turf on their stairs. So next slide, please. So I'm just trying to visually, now you guys just completely get this, but often when I talk, people have not seen people's houses and they don't understand. And in terms of what you guys are working on, you probably know, but I just want to point it out, that the healthcare system is in a complete flux right now, where they're starting to focus on quality over quantity, where it's going to be less billing per visit and more about outcomes. And that's why it's the perfect time to focus on things like home modification and other things that haven't really been paid for with healthcare dollars before, because more and more, as people see what drives healthcare costs, they will start to invest in fixing those things. Next slide, please. So this is a visual of the same point, which is that you don't have to look at the math or anything if you don't like statistics, but the idea is that you probably know that in any healthcare situation, a small percentage of people cost a big percentage of the dollars. So usually about the top 5% of people are responsible for about 50% of costs. That's true in Medicare, that's true in Medicaid, that's true in Blue Cross. And this is a graph showing you that the chronic conditions, where you see where it says 1+ and 2+ and 3+, that makes someone more likely to be in this top 5%. But where people really start to get expensive for a healthcare system is if they have functional limitations or need help with ADLs and IDLs. And so that's why it's so important, besides just that we care about people and we want them to be able to be functional, but from trying to get hospitals and health systems and the government to pay attention, this kind of a graph is important, because we can show them that being able to do their ADLs and their IDLs is essential to keeping down healthcare costs. Next slide, please. So we developed Capable, as I mentioned, and it's client directed, not just client centered. So it's not just convenient for the client, centered around them, the client actually decides what they want to be able to do to live meaningfully in their home. And it's a combination of 6 occupational therapy visits, 4 nurse visits, and a handyman budget of up to $1,300 over, and the whole thing is over 4 months. And the whole cost, including the handyman part, is about $2,800. And it's not your typical OT and nurse visits. They use the skills and discipline that they have from their knowledge of those disciplines, but the visits are different. That's more of a consultative, and I'll take you through that a little bit. Next slide, please. So this has a lot of advancing in it. So Karen, just like click, click, click while I'm talking. And I'll tell you if you're going too fast. Thank you. That's perfect. Keep on going. So it's a 4-month program. Thank you. At the beginning and at the end. Keep on clicking. The OT has the first 2 visits. You can keep on. Thank you. Whoa. Go back 1. And whoa, let me just close the door. Sorry, there's a band rehearsal in my house. My dog just opened the door to get away from the noise. So the occupational therapist has the first 2 visits, and in those visits helps the older adult think through what they like to do and what they would like to be able to do, and prioritize those. So they may say, I'd like to be able to stand long enough to prepare a meal. I'd like to be able to get down my front steps and into my daughter's car to go to church. I'd like to be able to take a bath for the pain that I'm in, for example. Then the OT combines his or her clinical knowledge with what those goals are and what the person's situation is. And together they brainstorm ways to do some of those things differently. And as we have the budget for the handyman, we don't have to just say, oh, it would be good if you had a grab bar. It would be good if you could fix the holes in your floor. We can actually do that. So then they make a work order for the handyman who implements it over a short period of time. And then the little nurse hat on the top, the nurse starts. And the nurse focuses on things like pain and depression and strength and medications, things that would interfere with the older adult being able to achieve the goals that they had set out. They also make nurse goals, things like I'd like to be in less pain, I'd like to work on fall prevention. And you can see that they're very overlapping goals between the OT and the nurse, but we give them a chance to set 3 goals with the OT and 3 with the nurse. And next slide, please. And we can skip this. This part was more for an academic, for people who would think, who were more interested in how to design a study. You know, I don't have to tell you guys how important the environment is, but I really like this picture. The one on the left and the right are obviously the same house, and it was 2 80-year-olds who lived in that house. And so it's just shocking to me that anyone, you know, if you had any lower leg weakness, that would be very difficult without banister. And we often use a second banister so that people can distribute their weight across, you know, across both. Okay. And I'm happy to answer questions as we go. So the question, how are you funded and is this private pay? Right now, we were funded by research funding at first, when I'm going to tell you the research results. And now it's in 16 places in 8 states, and each one is differently funded. There's no private pay so far. So far, it's all free to people through different mechanisms, and I'll tell you about those as we go. Next slide, please. So I was just mentioning the data I'm going to show you are from, thank you, Christina. The data I'm going to show you are from these 2 italicized, one is from National Institutes of Health and one is from CMS that runs Medicaid and Medicare. And then the other sites are all being piloted in different ways. Go ahead, next slide. This is just showing you that Baltimore is as a May, and the dots are people who've been incapable. So we're pretty much covering everything except for the very light purple areas are quite wealthy areas or wealthier areas. And in the other cities that we're not quite, we don't have as many people, but that's just a visual representation of what it looks like. Go ahead. Thank you for advancing.
Actually, I have a question.
Sure.
For the wealthier areas, I've just started doing more home modifications for on a private pay basis, and I'm pretty much just doing wealthy right now. And what I'm
Mm-hmm.
finding is
Mm-hmm.
those people are struggling because they have no idea where to go
Mm-hmm.
for help for the same sorts of things you're talking about as far as home modification, nursing
Absolutely.
services.
Absolutely. And I would never say that wealthier people, that I think this is a problem of aging more than of poverty, although the combination is difficult. And we are trying to build out models as well. And I think, for $3,000, you don't have to be so wealthy because, if you have three kids and they could each give $1,000, and then they know they've got a lot more peace of mind, and you're happier that, you don't have to be a millionaire for that.
Okay. I just wondered if could offer it to if you would offer it to the wealthier population, but let them pay for it out of pocket.
Absolutely. Absolutely. Yeah. The grant funding that we had was for low income people, but absolutely.
Oh, good. Thanks.
Um, okay. Next slide, please. So I know some people like data and some people don't like data. And just going to explain this briefly. Each one of these lines is a different person. And you can see on the left is a baseline, and on the right it says 5 months. So in between baseline and 5 months was when the program happened. And you can see that on average, most of the lines are going down, and that the actual average, the red line, is the average of these. And it goes from about 4 to about 2. And those are the number of different ADLs someone had difficulty with. So at the beginning, on average, they had difficulty with about 4. So let's say bathing, dressing, grooming, getting off the toilet. And at the end, they only had difficulty with 2 of those. And that's actually, it's remarkable. It's really rare in research and programs. And also, it's conservative because let's say, they might have gotten from very difficult to get into the tub to a little difficult. And that's not being caught in this because this is just did you have any difficulty. So this is really a remarkable outcome. Okay, next slide, please. This on the left is the same data, just looked at differently, showing you that 75% of the people improved, only 10% got worse. And with low income older adults over time, you would expect that just staying the same would be an improve, good, and that worsening might be more likely. And with the IADLs, 65% of the people improved. This is published in what you can see underneath in Health Affairs in the fall of last. And I can send citations for any of these. They're also on our website. Okay, next slide, please. We also decreased depressive symptoms by a clinically significant amount. This red line is about the same as an antidepressant does for people. And we weren't giving them a pill, of course, we were just helping them meet their goals. My favorite parts of Capable is just seeing their mood lift. You, Kat. We can talk later. Um, Next slide, please. Karen, can you advance to the next slide? Okay, thank you. So the previous slide was showing the same thing about depression, and then now this is showing you that in people who've been hospitalized, it's about the same improvement as people who haven't been. And so this is a real area of interest of ours, and we've found that we're decreasing hospitalizations and readmissions. Go ahead, next slide. And then one more click because it'll highlight where you're supposed to look. Thank you. So this was a paper in Health Affairs, which is a top health policy journal, showing that over a 2-year period, capable, if you look on the right of the blue circle, where it says Medicare expenditures, that per quarter, per patient, it was about $2,700 less than in a comparison group. And if you remember, capable only costs about that much. And this is saving in each quarter. And it lasts for about 2 years. So one way of thinking about it is that you break even on the first quarter, and then the next 7 quarters of 2 years, you're paying back or making money for the next people who need it. Go ahead, next slide. And what we found, I mentioned this, we're reducing readmissions, reducing observation stays, decreasing specialty care, and reducing nursing home admissions. Next slide, please. And now this is Medicaid, so you probably all know the difference, but Medicare is what 65 and some selected people under 65 have. Medicaid is for quite low-income people. And this is showing you, the 2 bars are showing you, if you see on the bottom where it says treatment and control, the treatment group is spending less overall, and the biggest difference is that dark red, that rust color, and that is inpatient, so that's hospitalization, and that's what's really driving it. The darker blue underneath is nursing home long-term care, and we expected to decrease that a fair amount, which we did. We didn't expect to be strong, but it makes sense because older adults are more likely to go to a hospital in any given year. So there's more opportunity to save money on that. Next slide, please. I think that you all probably have a good sense of how much occupational therapy would matter and home modification. So I'm just going to briefly tell you about a participant or two, because I'd rather be able to really discuss things with you. But so here's an example of someone who was really out of it, and after the first visit that the nurse and the OT had with her, they really thought she was should be in a nursing home now. Like, they just didn't think we were going to be able to do anything. But then and it took her literally 30 minutes to walk to the bathroom, which was just down the hall. But then the nurse made a medication calendar for her and realized that she was on 26 different medications, and that a lot of them were for pain, and she took them all at once. And so she was just really over medicated. And once the nurse helped her and her family figure that out, she was able to not, take them more correctly, and she became more alert. And then she got really involved in brainstorming her goals. And one of her goals was to be able to get towards the bathroom that took her 30 minutes at the beginning, and down the stairs and to her kitchen sink and wash her hair. And I mentioned that because that would never have been a goal I would have told her to do, right? Like, you wouldn't walk in and say, you need to wash your hair in the kitchen sink. But that was a really motivating goal to her. And this is that there's 2 secret sauces of capable. One is that we address the home environment and the person at the same time. But the other one is this goal setting about what they want to be able to do. And it's not just, simply ADLs or IDLs, and it's not simply medical. It's what would they like to do, to go to church, to play cards, to cook for the family, and then to address the home modifications and all of our support around those goals. Go ahead, can you go to the next slide? And this was another participant who really needed tiny things, but she didn't know it when we got her, and she was breathless from lack of control of her asthma, and she was in a fair amount of pain. And we just did very, very small things for her. We connected her with her primary care provider from before, who could get her on the right inhalers. She's been taking any pain medication because and so we switched to and choir claps and very strengthening your core and your legs. based on Otago exercise, which maybe some of you have used those with people. It's basically a pocket amplifier. But she, even though she sat in the second row, she couldn't hear the pastor. And we did some railing. These are all very small things, but now she can hear, and it all builds on each other, because now she can go places and not be breathless, and she can hear what people are saying. And she looked right at me and said, if I had 10,000 tongues and they could all speak at once, I couldn't praise the Capable program enough. And we really just changed her life. Next slide, please. So this is just summarizing what I've been saying, that low function is costly to the healthcare system. Older adults, of course, care about it more than they might care about their hemoglobin A1C or something that's just on a chart. It's usually ignored in the medical system, not by you guys, but the overall medical system. And we're showing from this data that it's modifiable. Go ahead and next slide. Next slide. Karen, I don't know, can you hear me for the next slide? Oh, and that's what, okay. Oh, I guess I just, these other slides are just showing that there's a lot of ways that we're leaning on, and that of the sites that are doing kinds of these. But why don't we get to your questions and your thoughts? I see them when they pop up and then they disappear. I'm not sure if there's a way of being able to see them all, or a way of how we do that.
There's not a lot of questions right now. There's one from Kathy about she lives in Baltimore.
Oh.
And she would like to serve individuals who would not qualify for the Capable program. Oh, here's a few right here.
Okay, great.
What are the go ahead.
Go ahead.
I was just going to read the boxes. Okay.
Well, so I just saw a couple pop up and then go, so I can't still see them, but I'll just say that if Johns Hopkins Nursing Capable, you get to our website, and I should have had the link there. I'm sorry. And you on that website, there's also a sidebar for how to get trained in Capable. Right now, we train in because you need also the nurse and the handyman. You know, you need like a program. In terms of where we are, the sites are San Diego, California, Burlington, Vermont, Greensboro, North Carolina, 5 cities in Michigan. Oh, Wendy, yeah, hi. Yeah, and you could speak up more too.
Hello.
Yeah, if you want to say anything, Wendy.
Well, I was just involved when it was just being initiated, the first year of the program, and then I've since moved to Florida, so I haven't really kept up with it since then. But
well, now it's in 4 places in Maine, and
fantastic.
They've put in the OT and the nurse part in through Midcoast Health, and so I think some of the questions that popped up were like how to expand it more. The trick is to figure out who would save money by decreasing the cost. Oh, and Monica Robinson, a place in Chicago for right now. And yes, that's the right. So the trick in terms of expanding is figuring out who would save the money, right? So you probably know about PACE programs and Medicaid waivers. There's a number of programs that have a financial incentive to put up the money, you know, the $800 per person, in order to save the money later on. Also, you know, it could be done through self-pay. you know, where, you know, you would have to get a case. The trick about if you just wanted to do it as self-pay on your own would be needing to be able to build up the client load, just like if you set up your own shingle to do anything else. I think there have been a couple other questions that have popped up and then disappeared. I was told there. Margie Quart,
I can tell you.
Okay.
This is Sheila O'Connor. I just want to tell you how you can see those questions.
Oh,
like
thank you. Okay.
Yes, if you go, there's up and down arrows on the far right of the question. They're all there. You can back up and just, they don't go away.
Oh, good. Thank you.
You're welcome.
Okay, so let's see. I guess I'll start at the top. People say they don't have a mic. Someone referred them. Okay, that's all about Florida. Okay, then that's about my voice. Okay, all right. How are you funded? Is this budget private pay? So right now, no, there's no private pay, but that's certainly an option. Kathy says she lives close to Baltimore, would be excited to assist if capable. Very nice, yeah. And so right now there's two, but we no longer are doing the research on it in Baltimore, but there's two programs that are doing it. They have very specific requirements for who gets in. So we, one is people who've been hospitalized recently at Johns Hopkins, and the other is people who are in the Johns Hopkins Accountable Care Organization. Then the 8 places where this is being offered, I think I covered all of them, but I realized that we need to make a little map on our website to show where they are. Any resources for expanding? I think the thing to do is to start with our website, but then the trick is figuring out, you know, who would pay for it. So in Dallas, so Texas, Austin, Texas is thinking about doing capable through a foundation. Denver, Colorado, there's one there. There's not one in Dallas that has come to us yet. OT to get involved in the project, it would be through a site that was doing it. And yes, so there's on our website you can see all of the publications, and the class is, yes, because the class is about $3,000, but that includes the license. You know, organizations pay that, individuals don't pay that. So that includes the license for the organization to do capable. And there's not one in Kentucky yet, but that would be great. Yes, that's the right email. I mean, the website. Monica Robinson, are you able to share who? I get that question, but maybe you could ask it again. Margie, that's interesting. Was it that recently that you applied? Because
yeah, it was I got a letter back at the end of June. Maybe it took about a month for them to get back to me. It's just like it's something online because I moved back to Baltimore in mid-July.
We had finished hiring at that point at June. So that must have been like
well, the letter, yeah, it came at the end of June, but I would still see it come up on the job website. So I was just curious. I didn't know what they were looking for.
No, I'm sure you would be perfect. It's just we left it open in case, and they all are doing great. So I'm sorry about that. Yes, it's true that Australia is implementing this or something similar. They call it iHarp there, and it's particularly for people with some cognitive decline, and they've added in a psychologist. But yes, that's true in Australia. And Chicago hasn't done it yet, but they're applying for a grant to do it. And how to lobby to get a program started in our area. I think that was a longer conversation to have about who, if it's on the state level or the city or the national. We do, I mean, we have gone back to CMS, who pays for Medicaid and Medicare, and said, look, you funded our research and we've shown that we decrease costs and that people like it and people improve. And so why don't you make it available to everyone through Medicare? And you know, I think that could eventually happen, but it's premature. And then a question from Bridget: does the location that's going to run Capable need a team first, then they take the class? Yeah, the class is for the people who are going to do it. Margie's question, I guess that's the question about the hiring. Do you have a contact or suggestion of who's talking to Kentucky? I don't know. Oh, sorry, maybe everyone else does. That's a good point. Sorry, I realize these aren't all for me. I can't say who, I don't think I'm allowed to say who's applying for the grant in Chicago, but I guess I could reach out through you guys and tell you if they get it. That's all the questions I see.
Sarah, do you know how the implementation is going in Michigan?
Yeah, so there's two different situations in Michigan. One is through the Medicaid waiver, where it has been in Flint, Detroit, Saginaw, and Grand Rapids. And it's been going well, and they have shown better outcomes for people on the Medicaid waiver who are getting capable there. And they added a social worker to the model. And they have decreased falls and decreased hospitalizations. And they're working on expanding it throughout the whole state. Their problem, and actually I would love it if you guys could fix this, their problem is that they say there's hardly any OTs in Michigan, and that they feel like they need to do some scaling with just the nurse and the home repair, which to me really guts the whole point of Capable. And so I don't know how much you guys know OTs in Michigan, but it would be great. I would love to bombard them with ideas of people they could hire.
Hey, Sarah.
Then the other place, yeah.
I have a company called Barrier Free Occupational Therapy, and I have occupational therapists that specialize in home mods all over the state. So if they want to connect with me,
oh my goodness.
I can set them up.
Oh my goodness. Okay, so
you have my
will you
email
write
address.
me tomorrow?
Yeah, let's talk.
Okay. Okay, great.
In fact,
then the other place,
if they need OTs anywhere in the country, this group has enough contacts where I bet we could set you up anywhere you.
Wow. That is great, because the other thing in another place that I won't say what they are because I don't want to get you all mad at them, but another place was having a hard time finding OT, and they really tried to talk me into letting them use a PT, and I just kept saying they're two different disciplines, two different trainings, and a PT for an OT. So anyway, so that would be great if I could reach out to you guys, because we are very clear that it's an OT role.
Thank you so much.
But yeah, Bethany, I know.
What did you say?
This is Bethany too. I know just because our agency is a waiver agent, a big part of it is education. So just educating the Medicaid director and helping them formulate it in their mind, because in their brains, OTs just don't do home mods. It's just not. It's a new concept for a lot of people, social workers, nurses. So this would be a really good advocacy opportunity, just to educate folks on the role of OT in this space.
That's great. And I always say, when people say they can't find OT, I say, well, every hospital has them, and OTs love this work a lot. And so, I know there are OTs. I just guarantee there's OTs. I think sometimes they don't want to pay enough, but that's something that we try to prepare them for. The price list.
Thank you. We love you more and more as this meeting goes on.
The other Michigan that's doing it is in Muskegon, Michigan, which is on the west coast of Michigan, and that is through that's not through the Medicaid waiver, that is through Trinity Health, which is I'm sorry?
I just thought maybe Senior Resources. I got a contract out there.
Oh, well, and so the nice thing about the one in Muskegon is that It's part of a national organization, and they explicitly funded this one to see if they wanted to make it nationwide through their different health centers. So it's exciting also.
Cool.
Anything in Savannah, Georgia? No, but no, I think Memphis is as close and not even close. If you are not a Medicaid provider, can you still be part? Yeah, it's only in Michigan Medicaid is paying for capable. Other places are doing it lots of different ways. And I agree to Philly. OTs have a lot. You know, I'm a nurse, and we always thought we were underdogs until I started working with OTs, and people say things like, "You mean PT, right?" Oh. So anything in Missouri? We've been talking a little bit with those wonderful people who do Tiger Place in the University of Missouri, and but we haven't got anything going with them. New York, yes. So this is Jay. New York City, we just got a big new grant to do capable in New York City in all 5 boroughs, and but the OTs and nurses need to be bilingual because they will have a lot of Latino clients as well. What group in Greensboro, North Carolina? I am going to have to look and get back to Karen, I guess, to tell you. What if we got a group of OTs together in an area? Could we do absolutely? I'm not against individual training. I just think that it would be hard to, you know, you just have to make it work. But yeah, I think that especially, you know, that if you sign on with some kind of platform or way of you know, I think that we get some nurses and get some OTs and get a relationship with a carpenter or someone, and you could offer it. You know, you could just start offering it. Rhode Island, nothing yet. And with translator apps, no. It's really got to be that you can really, really converse and know the culture and know be able to listen about daily life and so that we're really looking for bilingual people. You guys are an amazingly engaged crowd for 9 o'clock at night. At least on the East Coast anyway.
How do you do the selection for the OTs for the Capable program?
So we, you know, I think, you know, so I now am not running any of them except for one tiny pilot, but basically we look for positive people, you know, that there's very much, you need to be a kind of glass half full person. We look for home care experience or home experience in some kind of way. We look for good people skills. Try to require home experience, but sometimes we've had someone who just had only had hospital, but they did really well. I ask, you know, I've learned to interview well, to ask people a lot about their thoughts, and but we don't have any hard. They have to be a. Now I'm gonna get the letters wrong. OTRL, is that right? Mm-hmm. Yeah. They can't be a COTA. People have tried to say, well, maybe if the OTRL does the first visit, the COTA can implement, but really every visit is problem solving and clinical thinking, and so we have not said COTA could do. And then questions, yes, it's the VNA in Denver, and I don't know what OTR is. Oh, that's what you're saying, Indiana's, okay, yeah. And to clarify, no, it's $3,000 per person trained. I'm sorry to say. So, but that's why it's been organizations doing it rather than individuals, because you'd have to, you know, make that money back to make it worth the training.
Is there any way you think that we could set up a training that was either like via the GoToMeeting, or if you were going to do a training, several OTs or nurses, as well, but several OTs could come to the spot where you're doing the meeting or the training, so it would be, it would be more cost effective.
So already, if no one has to travel anywhere, there's online modules first that you do, and then 8 hours, either split into 2 blocks of 4 hours or 1 8-hour day. We do it through Zoom, like GoToMeeting, Skype, and there's no travel involved. Where should someone agency apply for a grant? So the places that have gotten the grants have tended to be, they've applied to like local foundations. So for example, in Denver, you guys probably know that like when a health system goes from not-profit to for-profit, they have to make a foundation to make the city or the place they're in healthier. So that a lot of places have that kind of a foundation, and they have to give away a certain amount of money each year for the health of the community. And so some of the places have gotten funding from a place like that. Those places are all over. And then, you could talk to your Medicaid program, in your state, or Medicare Advantage is, covers about half of people in Medicare, and they could maybe do a pilot and see if they like how it works for them. On the price structure, it's not really in my hands. It's because it's Johns Hopkins intellectual property, and we put a lot of money into making the online model and the time of the trainers and then the license. Thanks, Christina. So we may be running out of questions. I would direct you to our website, and also there's a really nice video that's just 90 seconds of one of our participants talking about Capables on our website, and she does an excellent job of saying how it's different than other services she's gotten before. So is there a designed plan to gather the data to support future funding? That's and then the data from the New York trial. And we're about to get some foundation funding to look across all of the sites that are already doing Capable to see what kind of outcomes they're having. So that's a further plan. You're welcome. And I see Karen's pulling up the website, and so if you go farther down, and you where it clicks to about the training, and then that's the video of Mrs. B. There's a different Mrs. B than the slides. And there's and if you go a list of all the publications, and there's also a part that says news that I think is a little lower down, and that click link, and we always talk about OT, for them to figure out what the nurse, but in the able part, the OT part, groups or trying to inspire someone.
I missed pretty much all of what you said. It breaks up for me for some reason.
Oh.
Is there a certain
so
spot
sorry.
you go?
I was just saying that just a little bit lower. Oh, yeah, in the news, see what says View News and Podcast Program. Right where your cursor just was a moment ago. Oh, well, anyway, people can explore. Yeah.
Yeah.
And there's podcasts, and there's a couple of videos and like a CBS News piece and PBS, and so you can also feel free just to use it to show like what OTs can do. You don't have to, you don't have to be trying to promote capability. And to me, is the overall thing is using, working with when people's functional goals and addressing the home and the person at the same time is a really promising approach. And people don't is capable. It's just a way of it. And Felice, what I do if you put your email address or phone number into then I could have this person contact you. I just don't think I'm applying for a grant.
Or if you just let me know, I'll let the whole group know. Anybody, for the Chicago area or anybody else who's starting new programs, if you're comfortable letting me know, then I'll spread the news to the entire group as well.
Okay, sure.
Is there anything our group can do to support you with the Capable program? I mean, this is a great program. We have a lot of people in our group. What can we do to help support you and make this Capable program even stronger?
What a lovely question. It's not something that I've spent time thinking about, and to put some thought into it. And so far, it's health systems that have come to me. I haven't had much. I would like to put some thought into it, but you can believe me, I'll get back to you.
Yeah.
And Carrie says we have a company called Capable Living in Louisville. Nice.
They'd be perfect, yeah.
And yes, and at AOTA, we have been, let's see. I guess we've presented at some of the state OTAs, and I don't think we have at the AOTA. We're also thinking about having like a training workshop at AOTA where people could come a day early and get trained all in person. So that might be. The secret sauce, someone says, Sheila says, the second part I was talking about, the person, the house, and at the same time is really key. So, for example, in some modifications like Sweden, might get on a list and then have it like a year later or 6 months later. And we've really found that fixing the stairs, fixing the bathtub, fixing the holes in the floor, all of that at the same time as you're decreasing someone's pain and getting them on the right medications and giving them energy conservation strategies, and all those together at the same time is what decreases their ADL difficulty.
If you would like, I'm sure that we have a group of people within this group that would be more than happy to assist in, helping you with whatever you would need help with to be a part of the AOTA.
Great. Okay.
I mean, if you're interested in that,
thank you. Yeah,
as far as being presenter,
we have close. We have close contacts with the AOTA, the DC people too. So, but still, it'd be, it's great to have all kinds, attack them from all fronts. Do you guys? There's just one in the summer, right? The Centennial.
It's actually in April usually, like the first week of April.
Okay.
Sometimes the second week.
Okay. Okay. Great. Okay. Good. April. All right. Okay. Well, thank you to everyone for your kind attention and for your thoughtful suggestions. And I guess I'll be in touch through Karen, and we'll make a whole OT army.
Yeah, we're at your back. We're at your whatever you need.
And thank you for what you guys do. And your work is so important. And I've been really trying to convince my daughter to become an OT, but she wants to be an artist. Oh well. All right. All right. Y'all take care.
Thank you so much, Sarah.
Thank
It's
you.
really great.
And thanks for your kind